is Seema Patel. I'm on the medical affairs team as a medical science liaison. And today I have the pleasure of introducing Dr. Rachel Shmuts, who will be presenting on the principles of psychotropic medication management in pregnancy and lactation. She'll be presenting for 45 minutes, and then we'll save 15 minutes at the end for a Q&A session. Because we cannot see or hear you, the best way to get your questions answered is by typing them in the Q&A box at the bottom of your screen. And we will make sure to answer those questions during the last 15 minutes. I will be moderating that session. So without further ado, I'd like to introduce our esteemed speaker, whose bio I'm sure you will all find very impressive. Dr. Shmuts is the inaugural Vice Chair of Education and an Associate Clinical Professor of the Department of Psychiatry at Rowan University School of Osteopathic Medicine in Southern New Jersey. She graduated from the University of Medicine and Dentistry of New Jersey School of Osteopathic Medicine in 2009 and pursued her general adult residency training at Thomas Jefferson University Hospital in Philadelphia. She then went on to complete a fellowship in consultation liaison psychiatry at the University of Pennsylvania, where she discovered her clinical passion in women's mental health. She then returned to her alma mater, where she started a women's mental health clinic and eased into several academic roles and contributed to the medical school's curriculum reform. She serves as the Brain and Behavioral Block Director for first-year medical students, Human Sexuality Intercession Director for second-year medical students, Clerkship Director for the third-year medical students, and Psychiatry Residency Program Director. In addition to all of her university commitments, Dr. Shmuts consults for transcranial magnetic stimulation and volunteers in her community. She is also a certified perinatal mental health care provider. All of this is to say that we are in excellent hands here today, having a certified perinatal mental health care provider speak on a women's mental health topic. And so without further ado, I'd like to pass the floor to our esteemed woman of the hour. Dr. Shmuts, take it away.
Thank you. And if anyone has a question as to whether I sleep or have free time, the answer is generally no. So thank you very much, Seema. I very much appreciate that really kind introduction. I'm going to share my screen. I do have a PowerPoint that's going to illustrate some highlights of what I want people to get out of the talk today, and then we'll go from there. Most of the talk is going to focus on pregnancy, and I'll touch on lactation a little bit at the end. If I don't get through it all, perhaps some of you may have some questions that I can address some of that content in. So here we go. So what I would like you to get out of this talk today, essentially by the end of it, is just to understand the course of psychiatric illness, risk factors, and sequelae of inadequately treated mental illness in the peripartum. We have to understand that premise before we talk about treatment. So I'll talk about that in particular, because there's a lot of misconceptions about what postpartum or perinatal depression is and the other psychiatric disorders during pregnancy and the postpartum. We'll talk about the safety categorization and the risk stratification of what the FDA is recommending and how we apply that clinically. Want to become familiar with basic approaches and what sort of questions you need to ask of your patients and of yourself as you're prescribing these medications, and then to develop some effective tools and how to confidently have these discussions with patients. So I know that I can't see you or have you interact, but just to give this one a thought, understand where we're going to start with the first objective and where we understand what we know about mental illness and pregnancy, with postpartum or perinatal depression being sort of the prototype because it's the most common. But what we need to know is what's the most significant predictor of postpartum depression? And actually it's depression during the pregnancy. 50% of postpartum mental health issues, including mood disorders and anxiety, start during the pregnancy. And so a lot of them are diagnosed retrospectively, but oftentimes we do have patients, especially ones who have a history of psychiatric illness or risk factors, will come during the pregnancy and ask for treatment, and we want to know how to treat them appropriately, and also understand that in doing so adequately and safely, you can help prevent a postpartum worsening. And the most common risk factor for depression, again, as the prototype for most perinatal mood and anxiety disorders, what's the most common risk factor for someone having symptoms during pregnancy is actually having a history of personal personal history of depression prior to pregnancy. So if a person has a history of any mental illness before pregnancy, pregnancy is going to confer a higher vulnerability for them to have relapse, recrudescence of their symptoms, or if they have a lot of risk factors without a personal history, pregnancy confers a vulnerability to develop first onset during pregnancy. So what do we need to know? What are patients going to ask when they come into our office about when the issue of having to be on a psychotropic medication or medication in general, truthfully, while they're pregnant? And these are the questions you're going to get. These are your, we always talk in consultation liaison psychiatry. What's the question? What's the focus? We're not doing a global assessment here. We need to know what the issue is. And these are going to be the focus questions. These are what you're going to have to thread through your evaluations. Patients are going to ask, is it safe to be on my medication? Should I stay on the medication I'm already on? Am I a bad mom for wanting to stay on my medication? I get that a lot, where the need to be on medication gets tied with sort of personal morality. Can I breastfeed on this medication? Some patients aren't at all worried about being on medication while they're pregnant, but they're much more worried about being on medication when they're breastfeeding. How much harm can this cause, which we always don't have the answer for? I say this is an incomplete question because there's harm that can happen if we don't treat, and that's going to be a large focus of this talk. If I stay on just a little bit of medication, will that help me? Will that help me? And that answer also is complicated. So these are the things that you're going to focus on and hear from your patients. So first and foremost, when a patient comes through your door who is pregnant or planning pregnancy and they need or want to or don't want to be on a medication, but medication might be indicated for their symptoms, how do we approach this? Everything in these patients and in this patient population is what I call a tripartite discussion. It's not just a risk versus benefit analysis. It is a risk versus benefit analysis. The risk of medication is the thing that everyone is concerned about. That's what's blown up in the media. That's what everybody reads about on blogs and posts and even in some scientific literature. Okay, that's what we're worried about. But very few practitioners or patients are aware of the discussion that needs to occur around the risk of untreated or poorly treated or undertreated mental illness during pregnancy. The truth is that we don't have great data on medications in general in pregnancy, but we have some really good data on what happens when people are actively unwell psychiatrically during their pregnancy. And that is a major part of the discussion, because if the risk of untreated illness is greater than the risk of the medication, then the medication is justified. And then, of course, the benefits of treatment. We always talk about risks, but we never really talk about benefits, right? We assume it's going to work, but in addition to feeling better, what are the ramifications of that? So we'll talk more about that. A lot of patients will come in and say, hey, this medication is category C, the old FDA safety categories. What should I do about that? I'm going to talk to you about what that means and how unuseful it is actually at this point in time. Other things to consider is as we go through pregnancy, the pharmacodynamics and kinetics of the pregnancy have an effect on on serum levels of medications. And sometimes medications need to be changed or increased based on the progress through the pregnancy and the timing in the pregnancy. And that needs to be considered as well. And then we have to understand that and this is well documented, that the more that providers don't know or are uncomfortable with prescribing in pregnancy, it leads to avoidance of discussion with patients, which leads to poorer outcomes. Patients will stop their meds, their active symptoms during their pregnancy. They don't know who to ask for help. And we know that the more knowledge that we have and the better we arm ourselves with this knowledge and implement it in this patient population, the better our patients will be. So, risk of medication. I'm going to talk a little bit about that first. We're always worried about congenital abnormalities, organ malformation, all sorts of things that are incompatible with life or may cause some medical issues later down the line if it is compatible with life. So what the general incidence of major birth defects in the general population in the United States, just all inclusive, medication, non-medication is all it is 1 to 3%. Keep that number in mind, please, because we're going to come back to that later. 1 to 3%. Most of which are due to unknown reasons. Up to 3/4 or 75% are due to unknown etiologies entirely. The remainder of the 25 is likely due to chromosomal abnormalities, birth, intrauterine trauma, or other sorts of things. Oops, hold on. My screen disappeared. I don't know if you can see it. Okay, there we go. So again, risk of medications. The FDA safety categorization, I'm sure most people have heard of this, the A through D and the X. And this is something that is still very quoted very, very often. But the truth of the matter is that this safety categorization has not been updated in over 40 years. And there's a lot of flaws with this, which I'm going to go into in the next slide. But just to refresh everyone's memory, and I hope most people here remember sort of what each of these categories mean. And I'll let you read this. But essentially, it's quantitative as opposed to qualitative. What each category does is says there are studies or there are not studies in humans, and what those studies might show. That's all it says. So the limitations of the FDA sort of the alphabetical categories is that there is almost no human data on these, and they only include randomized controlled trials or something that approximates randomized controlled trials. You can't really do RCTs these days in pregnant patients because they're not necessarily ethical. You can't give a pregnant patient a placebo and intentionally not treat them for something. And you can't give a pregnant patient a completely unknown med, where you have absolutely no data at all. Although sometimes we do that clinically, but you can't do that. So, this is based on very, very, very limited human data and also limited animal data. There's not just pregnancy is an exclusion category for most scientific research. So we really don't have a lot in pregnancy. New data and new considerations hasn't been incorporated into this safety categorization. It was developed 43 years ago, pretty antiquated. There is absolutely no mention in any of this categorization about the risk of untreated or undertreated mental illness during pregnancy and postpartum, and that the progression of the categories are misinterpreted as increasing potential for harm. And that is one way to interpret it, but it's a little bit misguided. If you went back and looked, it just says there are studies in humans, there are not studies in humans. If there's not studies in humans, they've been done in animals, and this one shows harm and this one may not. It's so general. So there might be, one study in humans that showed no adverse effects, and then it's a category B. But there might be 500 studies of the same medication in rats that shows adverse harm, and it's category C. It doesn't necessarily mean that, that example I gave means progression of harm, but it can be reversed. So there might be, so it doesn't tell you the quality of the data or the outcomes. It just tells you how many studies there are in humans and how many studies there are in animals. And that because of that, and what ends up happening there, because category C essentially says, no risk in animals, no human studies. So 90% of psychiatric medications, if not more, and 90% of drugs on the market are category C. So how helpful is that, right? So the rest of the categorizations for 10% of the drugs, not really helpful. And that, data on any particular medication within the same category also, implies that another medication in the same category confers the same risk, and that's not true. And again, discounts a lot of non-controlled data. A lot of the best data that we can get in pregnancy is observational data and cohort studies. And so that's not included in this labeling system. And then sometimes, depending on how much data is available, things get moved around per category. So it's like any given day, one might be a C in one day, it might be a D the next day, it might be a B next day. So it's not, I don't hang my hat on this at all in the patients that I see. In 2014 or 2015, actually, the FDA completely updated and revised the A through X categorization with something called the Pregnancy and Lactation Labeling Rule. And essentially it is a database of information that's expanded on each particular medication without necessarily assigning it a category, but it's a good summary of the available information on each medication that is inclusive of this labeling rule. And what it also does is it recategorizes some of the timing of exposure and how important that is with certain medications. So in the new system, when I say current labeling, that was the previous labeling. In the new labeling, it reorganizes sort of the pregnancy and lactation, and to have pregnancy also include labor and delivery, because essentially while you're in labor, you are still pregnant. So just reorganize that, get that conceptualization commercialization. The other thing that's really, really cool about this new rule is that there is data on medications and a category on the labeling on advice for females and males of reproductive potential, meaning that there are some medications that have very, very clear data that they're teratogenic, that there's recommendations in the new labeling rule for people who can have children to have used certain forms of birth control, sometimes 2 forms of birth control, 1 hormonal, 1 barrier, so that they don't get pregnant with exposure and have exposure to this medication of the fetus. So I think that's so useful for some of the medicines, not most of them, but some of the medicines. So in addition to pregnancy lactation, we have reproductive potential in the new labeling rule, which is really, I think it's super cool. Inclusive on the label for each of these medications that are included in the rule, there's information on pregnancy exposure and registry. So it's not just randomized controlled data, it's observational studies, retrospective, prospective, and any registry data, which there are quite a few registries, especially with Massachusetts General Hospital has registry data on large classes of medications. They give a risk summary, clinical considerations, and again, labor and delivery gets pushed back into the pregnancy category. There's for lactation, there's information. Essentially, lactation is a lot easier to deal with than pregnancy. You really are hanging your hat on one parameter, which is called the maternal serum infant ratio, or the relative infant dose. Essentially, how much of the medication ends up in the baby's blood compared to how much ends up in mom's blood after various phases of metabolism. And so that information is very helpful, and that's on the label as well. And then again, new section on females and males of reproductive potential. And it has recommendations not only on for contraception, how the effect of any particular medication may have on infertility, as well as recommendations for pregnancy testing. It's not a perfect system, though. Nothing's perfect, right? I've learned that as an adult, as a mom, and as a doctor. Nothing's perfect. So the label rule only applies to any prescription medications or biologics that came on the market after 2001. As many of you know, most of the psychiatric medications, and particularly the first line, like SSRIs at this point in time, came out well before 2001. So like the drug manufacturers don't have to comply if it came to the market after 2001. So so it doesn't help all the time. Over-the-counter products are not necessarily affected, and we know there's a lot. Pregnant patients are sometimes often using over-the-counter medications for symptomatic relief, either from anxiety or from pain. And then there doesn't seem to be a really wonderful system in place on how to ensure compliance from drug manufacturers. As far as I know, there's no fining, there's no, any sanctions or anything that occur if a drug manufacturer doesn't comply or submit this data to the FDA. So, all right, risk of medications, we're putting that aside. I just want to keep an eye on my time here. Okay, this is the biggest part of the discussion that gets missed with a lot of providers, but also like the part of the discussion that patients very much discount until it is brought to their attention. And it helps them refocus on themselves and the fetus as a dyad, and not just the fetus itself as being the most important thing. So bad things happen when people are mentally sick during pregnancy, if I had to put that in lay terms. What we have found, and there is a lot of really solid data supporting this, is that there's much higher utilization of over-the-counter medications, and usually in inappropriate amounts. I've had patients who came to me with severe anxiety and insomnia related to the anxiety, and they were so fearful of going on an antidepressant, but they were using, I had one patient that told me she was using Benadryl over the counter to sleep, or whatever, Unisom, which is usually Benadryl or something else. But she was taking 6 or 7 tablets a night. No good. I'd rather her be on Zoloft and have the anxiety under good control. That has all, just because something's over the counter and they use a lot of it doesn't mean it's any safer or confers less risk than something that we're prescribing. There's significantly higher medical comorbidity, especially in other like stress exacerbated states. So gestational diabetes, patients have higher cortisol due to stress, anxiety, depression, other mental illness, and that can exacerbate or instigate gestational diabetes. Gestational hypertension leads to poor nutrition and poor food choices, and lower exercise, lower engagement in prenatal care. It's much easier for a depressed patient who's lethargic and can't get out of bed to miss their ultrasound appointments, and then reduced compliance. In patients who have a history of substance use, there's much higher rates of relapse during pregnancy with comorbid psychiatric illness, difficulty with quitting smoking or relapse to smoking. There's correlation specifically with mental illness, active mental illness during pregnancy, and low birth weight and growth retardation, intrauterine growth restriction, and a higher rate of preterm delivery, which is actually a huge confounder because some of the SSRIs and other antidepressants also have a correlation with preterm delivery. We don't know what came first sometimes. It's always the patient is always thinking it's the med, it's the med, it's the med. But actually there's a huge confounding by indication in almost all of the data that we have in pregnancy. So is it the med or is it the reason you're taking the med? And most of the time there's been newer studies that have coming out and actually find that it's more the indication than in the medicine itself. And then later in pregnancy, higher risks of preeclampsia, higher risk of operative delivery, including vacuum-assisted delivery, forceps, and C-section, higher risk of NICU admission, and of course, higher risk of suicide and self-harm. And that goes into the postpartum period as well. Suicide and self-harm, but particularly completed suicide or in the first year is a number one cause of maternal death, actually in the first year of postpartum. It is still significantly lower than the general population, but is the number one cause of maternal death postpartum. So we have to be very careful. And then if there is any sort of psychotic element or departure from reality during the pregnancy, this puts the patient at huge risk for postpartum psychosis, which is a psychiatric emergency in the same way as suicide, homicide, delirium, because there confers a risk of infanticide. I'm not going to go into this, but I have a whole talk on postpartum psychosis. If anybody here remembers the case of Andrea Yates, maybe 15 years ago or longer, she had significant postpartum psychosis and killed all her children when she was in a psychotic state. We have to be very mindful of that. And then what happens during, what's the longitudinal course? What is the sort of flavor of mental illness during pregnancy if it's not treated, or even if it's treated? Lee Cohen, who's a very, very big guy in the reproductive psychiatry field, did something called a naturalistic study where he looked and saw patients with MDD and how the course of that MDD changed over the pregnancy. And what he found is that patients who come off their medications who are previously stable prior to pregnancy and they get pregnant and they come off their medications that have a 70% relapse rate for major depressive disorder symptoms, and actually a 30% relapse rate if they stay on their medications because of those changes in metabolism as we go through the pregnancy. And these rates are actually much higher even in bipolar disorder. Relapse rate for bipolar disorder, if a patient comes off their medication before the pregnancy, is 90% or higher. And I don't remember on the medications, but it's higher than 30%. So again, the changes in maternal metabolism and it affects drug levels, it affects therapeutic value. So it's really, really important to know that even patients who stay on their medications may get worse during the pregnancy because those medications might be metabolized very quickly. All right. So clearly, lots of risks, lots of scary things that can happen when someone is not stable from the mental illness during their pregnancy. Back to the risk of medications. Again, things we talk about with patients is that, they say, well, is there anything that doesn't go into the, to the fetal circulation? No, every medication crosses the placenta at different rates and for different reasons, but everything crosses the placenta, not except. The next point is that there's actually no psychotropics that are officially FDA approved for use in pregnancy. Everything is off-label, so you have to have sometimes multiple repeated informed consent discussions with patients saying, this is not FDA approved. FDA approval doesn't always mean anything. Sometimes it's just a marketing strategy, but they have to know that this is not approved specifically for pregnancy. The asterisk there is next to brexanolone, which came onto the market back in 2019 at this point in time. Some of you may or may not be aware of it, but it is a completely novel medication that is specifically FDA approved for postpartum depression, not peripartum or antepartum, but postpartum depression for moderate to severe symptoms with depression onset either during pregnancy or sometimes within the first 4 weeks. It's a 60-hour infusion. It's generally well tolerated, and it has really good response, very robust response and sustained response at this point in time. The FDA, so that is the only thing that has any specific pregnancy, not even pregnancy, postpartum indication at this point in time. Interestingly, the FDA, the Sage Therapeutics, and I have no stake in them, no disclosures. Sage Therapeutics that developed this compound has an oral version that they're finishing up trials now. They're putting in application in the FDA for major depressive disorder and also postpartum depression for an oral analog to this that seems to be have some promising data so far. So we might be seeing something really, some new, really cool novel stuff. This doesn't work on serotonin. It works on the GABA A receptor, which is completely different. And then when we talk about risk of medication, I get excited about that one, sorry. I can talk about that one for a full hour. But anyway, so when we talk about medication exposure, what do we talk about when we say teratogenicity? We're talking about congenital abnormalities. We're talking about neonatal syndrome. So during the pregnancy and growth, immediately after birth, and then long-term neurobehavioral effects. So that's what patients worry about. Anything is considered teratogenic is that if there's any rates of deformities or any growth issues over baseline risk. And remember I said before that the general population, the congenital malformation rate is 1 to 3%. Most of it is due to unknown etiology. And I'll, again, keep that number in mind. I'm going to come back to it. Risk may be conceptualized and also evaluated by time of exposure. So usually the first trimester is where we have the most concern because that's where most of the organ systems are forming and closing. But if there's exposure later on in the second and third trimesters, we start to worry about any potential effect on the neonatal period. Each organ system has their own sort of critical period, meaning, you know, the rapid expansion and development of that system. The first 4 weeks are really, really integral for brain formation and spinal cord closure from the neural tube. So oftentimes by the time patients find out they're pregnant, and have been taking a medication for whatever disorder, it may be already past the time where there might be effects, particularly on the spinal cord and sort of the nascent developmental stages of the brain. The first trimester is really considered mostly for congenital heart malformations. So we're really talking about early exposure with having the most risk on morphologic changes. So once we move past any potential, effect of medications on the organ formation, we talk about later about the effect on the neonatal period. And what is talked about the most here is something called neonatal adaptation syndrome, postnatal adaptation syndrome, perinatal abstinence syndrome, poor adaptation syndrome. Neonatal withdrawal, they all have they're all the same thing or part of the same constellation of symptoms. I like NAS. Neonatal adaptation syndrome. It's a difficulty adjusting to life outside the womb is really what it is. And it's a spectrum of physical and behavioral symptoms that are observed very early on, and they're usually attributed to some exposure during the pregnancy, later in the pregnancy, whether it's the medication exposure or, again, confounding by indication. It's sort of the depression itself having an effect on the baby's newborn behaviors. The SSRIs have a particular association with NAS. Again, not sure if there's confounding by indication, not really sure actually if it's what the rates of this actually are, because it's a very non-specific syndrome. Babies usually experience like some tremulousness, maybe some more lethargy, maybe poor suckling on average. It can be a little bit more severe than that and require a NICU admission, but most of the time it's fairly benign and fairly mild to moderate, and it disappears after about 2 weeks of life. So a lot of this just goes undiagnosed because you might just have what we call a difficult baby or a colicky baby. So it's temporary, usually benign, and it's usually very nonspecific. With specific agents, however, you can see more of a correlation that's attributed to certain medications. Like methadone, there is a syndrome of opioid withdrawal that we see in babies that's considered NAS or under the constellation of NAS. We can see floppy baby syndrome with exposure to benzodiazepines. And then also with high potency antipsychotics, you can sometimes see extrapyramidal symptoms in newborns. And this all just falls under the blanket of NAS. All right, and then down the line, when babies grow up that have had in utero exposure to certain medications and also exposure to untreated mental illness, like what happens? Well, we need more data on this, but essentially, these medications can have longer term effects because the CNS is really plastic and dynamic over time, even after neural tube closure. Some of these might be subtle and deep. There's very little data on longitudinal data on these things following students, there's my slip, following babies. on children through their teenage years and early adulthood. It's very hard to study that population in enough numbers to get an understanding. And there's, again, no way sometimes to determine whether there's this nature versus nurture argument. Like, was it exposure to the med in utero that caused this child to have an intentional ADHD later on? Or is there a significant family history? Or do they live with someone who has really bad uncontrolled ADHD and they learn to model those behaviors? One of the examples I give here is actually many, many years ago. I mean, cocaine is bad in pregnancy. Like, don't do cocaine in pregnancy, no matter what. It can cause all sorts of problems with the placenta. But from a brain development standpoint, what they found is that a lot of children exposed to cocaine in utero had attentional issues, neurobehavioral issues, depression, anxiety, and other substance use issues later on in life in very small studies. But really what was determined later on, and an explanation of that data, is that it more was in the environment that they grew up in, living in a home where cocaine was being used, or living in an environment where there was neglect because of substance use, had much more of an influence on the patient, on the kid's development of these issues, than the actual agent of the cocaine on the brain development itself. Similarly, valproic acid is notorious for causing major congenital abnormalities with the rate of up to 40%, intellectual disability, neural tube closure issues, all sorts of stuff. So clearly that has much more of an impact on brain development compared to like cocaine in utero. So just using those two different examples. And then we just need more data, no problem, no doubt about it. The data we have, again, it's not randomized controlled trials, and so we do the best we can. The data we have on most medications is limited, and any one particular medication that doesn't fit into any sort of drug class, even more so. So we need a lot more data of observational prospective data with more numbers in pregnant patients. Like I tell people, like, think about at any time in the world, how many people are capable of being pregnant? All right, slash that. How many of those people are actually pregnant? Okay, slash that. All right, how many of those people have mental illness? Cut it down more. How many of those patients are on any medication? Cut it down more. And then how many of them are on Wellbutrin? It takes so long to find enough patients and then match controls to like get enough to demonstrate any sort of, increase in problems. So this is a long and tedious and grand sort of scale that we have to gather this data over time. One other thing is that you might read some studies, or at least in the lay literature that patients are reading, is that there's always this description of data as relative risk versus absolute risk. And relative risk is really like, it's like the 2-fold increase, the 10-fold increase, whatever. Absolute risk is so much more descriptive. So like for lithium, one of you may be able to correct me if I'm wrong. I can never like remember it exactly, but I think it's like 1 in 1,000 babies exposed to lithium end up with Epstein's anomaly. 1 in 1,000, like that's the absolute risk. But or the baseline risk, the baseline risk is 1 in 1,000. For lithium, it's like 2 in 1,000. So the layperson might say lithium doubles the risk of congenital malformation. That's a lot scarier than saying 2 in 1,000 babies exposed, have this with exposure to lithium. So I always reorient back to absolute risk versus relative risk. A lot of the data that we have that's retrospective actually looks at pharmacy data. So if a patient filled a prescription within 3 months of pregnancy or during the first 3 months of pregnancy, they consider that an exposure. We all know that not every patient who picks up a prescription from a pharmacy actually takes the medication. For all we know, they picked it up and never took it. For all we know, they took it for 3 days and then got pregnant 3 weeks later. Like, not exactly accurate. So, and again, very, very difficult in the way that most of these studies are designed is to tease out confounding by indication. What sort of the lay literature, social media, exposure to unrefined medical information causes the worsening of the social stigma of having to be on medication during pregnancy. So, a lot of media influence, celebrities we talk about not being on things can have a big influence on people. The availability heuristic plays a major role in how patients feel about being on medication during pregnancy. My cousin's sister's son was born with 3 eyes because she took Zoloft during the pregnancy. That's not good data, okay? And then, of course, if the partner is not on board and doesn't have the psychoeducation that you're going to give to your patient, that makes it very difficult for the patient to take the medication as well if they don't have the support or the awareness that they have when taking it, all right? And oftentimes maternal self-esteem is tied to not wanting to cause harm to the fetus. They're willing to be sick if the baby's okay, and that's not okay. Like, I always do a lot of reorientation. Like, If you're not well, the baby won't be well. You have to be well for the baby to be well. They are just sort of pulling the influence up is very important. All right. So approach to treatment here is that we always have the patient has to make the decision in the end, but it's meant to be collaborative. It's meant to be individualized. So I've had a lot of people say to me, what's your treatment of choice? What's your drug of choice, your SSRI of choice for pregnancy, to use in pregnancy? The answer is it's not one medication. Has the patient been on anything and what worked for them? Because then if the benefits outweigh the risk, then that's the right medication. A lot of people will answer Zoloft. Okay, Zoloft has the most data, but if a patient was on Zoloft before and it didn't work for them, I'm not going to choose Zoloft. Very, very individualized. And the way that we prescribe medications is very case by case in each patient. Preconception counseling is the best because if they already have a mental illness and they're already on a medication or a bunch of medications, if you have enough time, and in order to sort of have them on as little medication as possible, but still be well, you might be able to do some tapers and manipulations and find sort of the lowest effective dose for them to go into a healthy pregnancy. So it's always the best to like have this whole conversation with patients before they're even pregnant. Not always possible. 50% of pregnancies are unplanned. But if it's possible, those are great. You always have to focus on that tripartite discussion, risk of medication, risk of untreated mental illness with a major focus on that. And then of course the benefits of treatment. And the things to consider are how sick is the patient and how sick has the patient been in the past? Because if they've only had mild to moderate depression, you might be able to get away with psychotherapy alone and no psychotropics, especially if they've never been on anything before. But if you have a patient who's had severe bipolar disorder, who's been hospitalized when they're depressed, who's been hospitalized when they're manic, and they're on 3 medications, and this is as well as they've ever been, that really means, that lends itself to more medication prescription. Again, how long what the course of their illness has been in the past. And also if how they've done on previous tapers. I had a really wonderful patient who came with great documentation history from a previous psychiatrist who tried multiple tapers she was on 5 medications over the years, and the psychiatrist had documented how she did on every taper. And that was very helpful to me because it was able to justify for me, okay, she definitely needs this one. She definitely needs this one. Oh, maybe she doesn't need this one. Also, the stage of pregnancy. I mean, if you have and that might help you determine dosing and understand that maybe their pre-pregnancy dose may be too low and they might need more. If they have plans to breastfeed, because there are some medications that seem to not have a whole lot of issues during the pregnancy and no increased risk that we can document, but might have a high relative infant dose of breastfeeding. For example, this is the reverse of what I just said, but valproic acid has major correlation with congenital abnormalities, mental retardation. Sorry, that's not the term anymore. Intellectual disability, neurobehavioral effect, but actually has a low relative infant dose in breastfeeding. So they are not mutually exclusive. The patients always assume like if it's safe in pregnancy, it's safe in lactation. It's actually completely different parameters. And then, how are they functioning? They might come to you on medications that are like, 50 milligrams of sertraline and they're not doing well. Well, maybe we need to increase even before you get pregnant or while you're pregnant, because you may not be optimized and there's that risk of undertreated or poorly treated a mental illness during pregnancy. So all these things need to be very seriously considered. What are the major agents that we're talking about with mental illness during pregnancy? Obviously, the SSRIs are first line for pregnant patients, just as they are first line for non-pregnant patients. And a lot of times I sort of think a lot of people, again, will ask me, like, what's your favorite one to use in pregnancy? It's my favorite one to use in pregnancy if it's the favorite one I use in non-pregnancy. I always ask myself, if this patient wasn't pregnant, what would I do? What's the best treatment for this patient? What's the safest treatment for that patient? And then the second question is, does the pregnancy affect that medical recommendation? And a lot of the times it doesn't. But we're sometimes using some of the atypical antidepressants like venlafaxine, bupropion, mirtazapine. I use a fair amount of mood stabilizers, including not so much the antiepileptics, but the atypical antipsychotics. And sometimes we're talking a little bit about benzos and sometimes beta blockers as well. So we talk, I'm going to brush over that just for the sake of time. So again, this is just a summary slide, is that we have more information usually. All right, so again, the relative risks are overestimated. The absolute risk for most medications is actually pretty small. We have older agents with more data that might be more helpful to use than with some of the brand new stuff, in particular some of the brand new antidepressants. And then you may, very rarely can we get away with moderate to severe illness on therapy or other non-pharmacologic treatments alone. So severe illness, moderate illness usually requires medication intervention, and that It's a risk versus benefit analysis. We always need that middle risk. Always try to do monotherapy when effective. So the lowest of my always approach, okay, figure out what meds I would use. Does the pregnancy affect that? And my third rule is I want to keep the lowest effective dose for the shortest duration possible in monotherapy if possible. For one person, that might be sertraline 50 milligrams for the duration of the whole pregnancy and they stay well. For another person, that might mean lamotrigine, quetiapine, sertraline, and this, as long as they're well and there's no, then the benefit outweighs the risks of the medication and the untreated illness, then that's that person's regimen. But I always try to keep it as low as long as it's effective. To answer a question that a patient may ask you, if I stay on just a little of my medication, will that reduce my risk of problems with, and the effect of the mental illness? And usually if that low dose doesn't work, then no, it's not worth it because the benefits don't outweigh the risk. We actually call that double exposure. It's exposing the fetus to a medication that's not as effective, and it exposes the fetus to untreated or poorly treated mental illness during pregnancy. So we have to justify the medication by risk versus benefit analysis at the right dose. Okay, that's the most important. We want to maximize non-pharmacologic strategies, exercise, healthy eating, complementary treatments that seem to be, safe in pregnancy, transcranial magnetic stimulation. For very severe illness where medication isn't working, ECT is not a contraindication in pregnancy. Okay, so all of these other things, I'm not going to go into too much of that. All right, we got 2 minutes to go through lactation and then I'll take questions. Lactation is a lot more straightforward in my opinion. So we all know the benefits of breastfeeding. Again, risk versus benefit analysis. So really here we're focusing on risk of medication versus risk of baby, risk of those, that's one risk. And then the benefit of medication. And if benefits outweigh risk, then it could be justified. What we really need to focus on here is what the data says about the relative infant dose. And I tell patients all the time, if you're taking a medication during pregnancy, 100% of that blood goes through the placenta and the baby will see whatever serum dose you get, it'll see a similar dose in their serum when you're pregnant. But when they're out and you're breastfeeding, there's a lot more filtration of that medication that occurs. I tell them it has to go through your mouth most of the time, goes through your digestive system, gets broken apart by your liver most of the time, dumped into your blood system, dumped into your breast milk, and then go through the whole process again for the babies before it gets into their system, into their serum. And if anything is under 10% or less, that generally confers a low risk of side effects in the fetus. Sometimes we have medications that are slightly elevated or have variable relative infant dose, but data might show that there's not a lot of clinical significance to that. Particularly one of them is lamotrigine. Lamotrigine has very variable relative infant doses, but there does not seem to be any adverse effects on the baby regularly at higher relative infant doses. So we use it very often. So there you have to attach sort of a clinical significance to that based on the data that we have. All right, passage into breast milk can also be affected by the composition of the breast milk, lipid solubility, water solubility, and protein. So really, there's a lot of variables as to what goes into a relative infant dose in the end. However, relative infant dose under 10% generally means lower risk of side effects in baby, but that doesn't mean no side effects. I don't think we can ever say, oh no, this baby won't have side effects from any given medication. We can't predict that. So if there's too much that goes into the serum, they can have toxicity. There is a thought when drug levels are too low, that there could be a withdrawal. That's not, I got to take that out. That hasn't really been proven. But even at normal or acceptable doses, there can be side effects in the baby. But like I said, relative infant dose under 10%, there's a lower risk of that. Hold on, my mail always wants to open up on me. Give me 1 second. You guys can only see my Google screen, right? You can't see my mail, I'm hoping.
Yeah, we can only see your slides.
All right, good. All right, sorry. I'm just having my my internal monologue outside. Okay, so medications that we use in breastfeeding, a lot of the antidepressants have very low relative infant doses, usually under 5%, some of them even under 1%. Ones that have a very high transmission through the placenta may have less in the milk. It really, the exposure during pregnancy does not necessarily correlate with the exposure in lactation. So lithium in and of itself, we will just touch on that, is very controversial. It has very variable relative infant doses. When I started doing this type of medicine about 7 years ago, nobody did lithium in breastfeeding. Nobody did. It was too much monitoring. You had to monitor the baby every week. You still have to do that, but people are becoming more and more comfortable with it. I am not, but at Mass General and in other sort of places that are a little bit more cavalier on the cutting edge of reproductive medicine technology are a little bit more open to it. So things are changing over time because, again, higher doses of exposure in the baby may not actually mean a clinical problem. All right. So approaches to treatment, we do a lot of psychoeducation. I make sure that if a patient is taking a medication while they're breastfeeding, that they collaborate and let the pediatrician know, and try to involve a discussion in that pediatrician so that if there is anything that happens in the baby, that is on their differential to consider. I try to involve, this is a very interdisciplinary field. As you can imagine, I talk to a lot of pediatricians, I talk to a lot of pharmacists, I talk to a lot of OB/GYNs, and we need to really rally around these patients because it's really, really important that we're all on the same page and then the patients are safe, protected, and well cared for. And that means their mental illness is treated properly as well. There's caveats and data as well in lactation and pregnancy, mostly with like sort of just the way studies are varied. They're difficult to summarize and do any meta-analysis. Again, not a lot of studies in humans. As far as relative infant dosing is concerned, it's not something we measure routinely clinically. There are some research studies, case reports, case series for which we get averages. You can access a lot of that information on a variety of resources, including LaxMed and Reproductive, and Thomas Hale's website called Medications in Mother's Milk. These are all really great resources for that sort of data. So just summary and take-home points is that no medication is absolutely safe, right? I tell people, except prenatal vitamin and folate, nothing has no problems or no potential problems in pregnancy. You got to consider the current data. You got to do a risk versus benefit analysis and try to approach each patient individually, and then try to do the lowest effective dose for the shortest duration of time. And again, that means very different things for different people. And now we're up to questions, and these are my babies. I always give them a little feature presentation at the end there. And then that's it, I'm done.
Thank you, Dr. Shmuts. That was an excellent presentation. I already know that you've given a lot of things to think about for our audience. I'm going to let people think about some of the questions that they want to ask. In the meantime, I have my own question. I really appreciated, you talking about the risk of untreated illness. I think even among patients and even in the medical community, it's not talked about enough. And whenever it comes to SSRI treatment for depression, people, as you alluded in your presentation, they think of Zoloft as the best option or the preferred option. Mm-hmm. Are there actually any preferred SSRI options? And on that same note, is Paxil a drug that we should not be using in pregnancy?
Love this question. Let's talk. Okay, so why do people jump to Zoloft? A lot of the OBs, and there's nothing wrong with this, just want to, jump to Zoloft. Zoloft is everywhere. It's sort of become the unofficial poster child what to use in pregnancy. The only reason is because Zoloft has kind of been around one of the longer times, Prozac, Zoloft, really some of the older SSRIs. There's just more data available on Zoloft, but the outcomes of that data are no different than any of the other SSRIs, with the exception of maybe Paxil, and I'll talk to them. So, in a patient who has no psychiatric history, who is presenting for the first time with depression, anxiety during the pregnancy, and you need to treat them, Zoloft's a good place to start, okay? Because we have that data. But if you have a patient with a history of depression, anxiety, and they're having worsening of symptoms, or they're developing symptoms during pregnancy, or they're having a relapse and they have had, you have to consider their medication history. If they've been on Zoloft and Zoloft didn't work or only worked partially, you may not want to go with Zoloft. I'm going to find out. So the answer to your question is there one? Whatever worked for that patient before. So if they tell me that Paxil was the only thing that ever kept them well, Paxil might be the medication. That would be the only, and then that brings me to your next question. That would be the only circumstance in which I would prescribe Paxil, not only in pregnancy, but also in non-pregnancy. I don't like Paxil, has a lot of side effects, has a lot of drug-drug interactions, has the bad withdrawal syndrome. But the benefit outweighs the risk. If the patient says, nothing else ever worked for me, this is the best medicine for me, then the benefits outweigh the risk. Paxil is a little controversial in addition to all the sort of normal issues with it. And because the initial data that came out on Paxil did show a slightly increased rate of atrial septal defect, ventral septal defect in utero. It hasn't necessarily been replicated, that data, because nobody really prescribes it anymore anyway. So it's not, it's hard to gather a data set for that, one. Two, the clinical significance of those ASDs and VSDs has yet to be eluded, meaning most ASDs and VSDs, due to any reason, close on their own within the first 4 months of life. So that slightly increasing, if there is a causative or even correlative relationship between Paxil and those abnormalities, they may not have major clinical significance. I would be more interested to see if Paxil had any, had any correlation with ASDs and VSDs that needed surgery or medication management. But most of them in general are small and heal on their own. So Paxil is not as bad as I think we thought it to be in pregnancy, but it's also, it's bad for other reasons that I would consider global, not just for pregnant patients. So I try to avoid it in general. But so again, one circumstance in which I say, yes, let's do Paxil is if it's the only thing that ever worked for them. Does that make sense?
Yes,
Okay.
absolutely. That makes sense. Thank you. I think we have a couple of other questions in here. One is, if you had a bipolar patient stable on lithium level of 0.6, would you consider this or transition to an anti-epileptic? I guess you answered this a little bit in your presentation as well.
If they're stable, I keep them on it. And 0.6 is good. All right. So we know that, like, if someone's not under good control, with their lithium or any other thing that you check drug levels for, you'll check the level and then you can increase it within the therapeutic range. But if someone tells me they're well, and even if they're subtherapeutic, keep them on it. I don't get them in the therapeutic range. It's therapeutic for them for one reason or another.
Right.
If a patient is well and stable on lithium and they go into our pregnancy, we keep them on the lithium. We have additional monitoring that we do specifically for Epstein's anomaly and other things. So I almost always involve maternal fetal medicine. They almost always get a high resolution echocardiogram at 16 to 18 weeks. They do a very thorough exam on the anatomy scan and stuff like that. So there are many more, there's more monitoring particularly with lithium. And it's amazing what they can do in utero now. So if there is evidence of Epstein's anomaly, depending on where they are in the country and what access they have to certain services, they can do in utero cardiac surgery to repair it before the baby's born. It's like totally insane. So no, the question, if someone's stable on their meds, we just monitor, with one exception, valproic acid. I don't put anyone who has a uterus or anyone could carry a baby on that, whether they're pregnant or not. It has such a strong correlation with problems. So if they're stable on their valproic acid and they enter into a pregnancy or they're planning a pregnancy, I do try to change that to another anti-epileptic or another mood stabilizer, like an atypical antipsychotic, at all costs. If I do, let's say in ideal stage, they're planning a pregnancy, we have time, and they decompensate and nothing I do works, then I'll put them back on the valproic acid. But what I find is that something else will work. I put very few people on valproic acid for a variety of reasons, but all of my reproductive patients, no.
Right. You actually answered one of the questions that I was going to ask later, but it looks like we have a couple of other ones. I'm going to try to see them in the order that they came. So the next one is, can you give more information on the safest second generation antipsychotics to use for postpartum breastfeeding moms needing treatment for bipolar disorder?
Great
question. I guess safest second generation.
So, second generation. So the data, a lot of the data that we've had over the last couple of years on atypical antipsychotics in pregnancy and postpartum is coming out of the Mass General Registry. And they're sort of constantly publishing on their outcomes. There are the ones that, there's not any one in particular during lactation. Again, what works best for the patient. I'm not going to put somebody on aripiprazole if Risperdal kept them stable. That being said, the more, Risperdal being more typical can have more an effect on milk supply, through the dopamine and prolactin pathway. So we try to avoid, I guess I can say, the ones that might have an effect on milk supply if the patient is breastfeeding. And there might be some strategies that go with that if they do have to be on Risperdal. But I try, it really depends, like what worked for the patient, what kept them stable, what can they tolerate. Just sort of keeping in mind the effect of on breast milk supply and nursing, which they can have. Most of them, if not all of them, have relative infant doses that are under the 10%. So it's as far as the neonatal exposure via breast milk, most of them are fairly comparable.
Great. So the next question is, any thoughts on sleep aids in pregnancy? I know this tends to be a popular question.
Sure. So, interesting. So, a couple of things. Of course, we always try to do non-pharmacologic behavioral interventions first and foremost. I find that most people have pretty awful sleep hygiene, especially during pregnancy. So we do a whole sort of evaluation on sleep hygiene and practicing those behaviors. Most people are not terribly compliant with those, but those can have a very healthy effect on sleep. Then we try to go to things that are, if we do need a pharmacologic, that sort of have more data, have been tried and true and been around for a long time. A lot of patients go to sort of the antihistamine medications, in part because they can also have an antiemetic effect. One of the more popular antiemetics that we use in pregnancy is called diclegis, and it's a combination of doxylamine and vitamin B6. So if they're on that for pregnancy-related nausea and vomiting anyway, that can definitely help with sleep. Some of the Unisom and over-the-counter medications for sleep do include doxylamine. Most of them include diphenhydramine, which is very similar. But we try to say just as needed, right? Lowest effective dose for the shortest duration possible. Sometimes sleep problems are normal and we have to validate and sort of just reassure that they improve. They can be pretty severe during the first and third trimester, improve during the second trimester. So some of it is just reorientation and normalizing sleep deprivation in pregnancy, which can be normal. If it's sleep deprivation or difficulty falling asleep related to their mental disorder, like severe anxiety or OCD, then treatment of the underlying disorder without a sleep aid, an SSRI for any one of those, will also improve sleep, as the symptoms of the disorder improve. Melatonin doesn't have a tremendous amount of data, but it's thought to be, there doesn't seem to be any major or specific risks associated with that. So we sometimes use melatonin. A lot of providers out there will use magnesium as well in low dose, in moderate doses to help with sedation at night. Again, depending on what the underlying mood disorder is, if you have someone with bipolar or you need to augment an SSRI, we may want to use a sedating atypical to sort of get two bangs for your buck. I try to maximize, I try to look where in other ways, if they're on any other type of medication that's sedating, or they could be on to sort of couple that treatment of the mood disorder in to help with the sleep, if that makes sense. So again, totally individual.
Right.
It really just depends on the patient, really.
Yeah. I think that's some of the biggest takeaways I've had from this is really individualizing treatment for everybody. There's no black and white in psychiatry, right? So we really have to understand who we're treating. I think we're just about on the hour. I know that we had a couple of more questions, but I think that just means that we're going to need to have you back. Maybe I know someone mentioned the postpartum psychosis topic, but I know this can be a quite intimidating and complicated topic for a lot of clinicians. So I know a lot of people really appreciate you coming here and talking to us about this. And it was an excellent presentation. I'd like to thank everyone who joined. We will have a recording of this on our website on genomind.com/360. And thank you for joining, and we hope to see you at future grand rounds. Thanks again, Dr. Shmuts.
Thank you so much. Thank you for having me. I really appreciate it.
Of course. Thanks for being here. All right. Take care, everyone.